Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week marks the start of our new academic year at the college. And with this episode, we are also launching the 4th season of this podcast. It's hard to believe, but next year, CoROM, as a nonprofit foundation, will be 10 years of age. I founded CoROM back in 2016. The following 3 years were spent navigating the challenging application process to become a degree-granting institution. It was an arduous journey, and I won't bore you with the details, but it was a profound challenge for us to get through that hoop. It was a profound challenge for us to get that accreditation. But by early 2019, we enrolled our very first remote paramedic practice students, with a cohort of just 16 people. Since then, we have grown tremendously. This autumn semester, we have over 100 students enrolled across our 4 academic programs. Our faculty has expanded significantly from those early humble beginnings to having more than 20 teaching faculty and support staff. In this episode, I will be speaking with the leaders of our 3 postgraduate programs. First, we'll chat with Dr. Ella Corrick, who oversees our doctorate in health sciences. Then, I'll speak with Dr. Csaba Dioszeghy, program director for the Masters of Austere Critical Care. And finally, we'll have a chat with Dr. Nick Zuber, who leads our Masters of Global Health. Next week, we'll dedicate an entire episode to our flagship program, the Bachelor's in Remote Paramedic Practice, where Dr. Tom Mallinson and I will discuss the history, the current developments, and the future upgrades to our program. But for now, let's begin by speaking with Dr. Ella Corrick about our doctorate program. Our next guest is Dr. Ella Corrick, who is an MD PhD. She's alumnus from Oxford University in UK, and she runs our Doctor of Health Studies program. Ella, welcome back to the podcast.
Thanks for having me again, Aebhric.
So what do you have planned for the DHS this year?
Well, it's an exciting year because we've got a bigger student cohort coming in this year. Like lots of doctoral programs, we're smaller than some of the other programs, but our previous year groups have maxed out at 5, and we've got 11 students incoming for 2025. And I'm really, really pleased because with any online program, I think a challenge is giving students a sense of community, and it can be quite isolating, I think, for some people studying online. And our previous cohorts, from what I can tell, have formed quite strong friendships between them with their peers. But I think having a larger cohort this year is going to help us start building a sense of community, and I'm going to really encourage the students and try and facilitate there being get-togethers for students that aren't necessarily faculty-led, so they can, share the challenges, talk about their projects without necessarily having faculty butting in, and start giving them that sense of being part of a community, which is easier to generate with an in-person college, but I think can totally be done with online programs if you put a bit of effort in.
There are tons and tons of online doctorates now, so we're not breaking new ground, but we are definitely incorporating that momentum that we see worldwide.
And I think there is a big range of what online doctorates provide. There are programs in some countries that don't have strong governance over what people can call a doctorate. There's 1-year doctorates, and I think they provide something very different to, thankfully, the Malta Higher Education Authority does have quite strict governance over what you can call a doctorate. And I'm actually in the process of applying to see if we can change our post-nominal to become PhD rather than DHS, because I think the amount of work that our students are putting into their research is easily comparable to a PhD. So although it's got some taught elements, in the first 2 years, students have modules that they have to do assignments for. They have a minimum of 2 years to exclusively do their independent research project, with a couple of faculty advisors. And so the amount of research, the kind of quality and volume of research we're expecting of our students, I think is certainly comparable to a PhD. And the focus is very much on, in those first 2 years, developing the skills they need so that once they come to the research element, they genuinely are leading it and doing it independently, but with input and advice from experienced faculty.
It's interesting that you mentioned the PhD. When we applied for this is all my fault in all fairness. When we applied for this, when we went through this is by far the most difficult program to get approved. We were getting feedback from peer reviews. So they go through 3 different peer review processes. And 2 of the 3 were like, we suggest you change this to a PhD instead of a DHS because this is a PhD. And I kind of stepped in. I'm like, well, I don't know, we're medical. So now I'm sorry. I'm sorry that I didn't jump on that.
I have had conversations with current and incoming students about how they would feel if it changes to PhD. And interestingly, I think for people who are coming from allied health professional backgrounds, some of the people who are from nursing backgrounds, physio backgrounds that I've spoken to have said they might have felt intimidated to apply for a PhD program because they didn't feel they were ready for that, even coming out of their masters. And so I think that some people look for professional doctorates because they don't want the level of independence of a PhD. But I think our program has that balance. I hate feeling like a salesperson, but I genuinely do feel like our program does this quite well, of having some structure in the early years that slowly hand over all of the control to the students so that by the time they hit their research phase, they should be used to having to drive their own progress. So it'll be interesting to see if we do get accepted as a PhD instead of DHS, whether we need to slightly change the way we market the program to make sure we're not putting people off who would be unnecessarily intimidated.
We'll have to sit down and chat because knowing the EU system and the MFHA system, there might be a way to change this into a PhD program, expand it a bit, and then be able to have an exit award of a DHS. So if for those that don't want the rigors of a full PhD, they can exit with a DHS, or does that make sense?
I think the exit, if people were to exit earlier, I don't think they should still get a doctorate if they haven't completed the full program, because I feel like that might undervalue the completion of the program. But I would think a good exit qualification would be an MRes, so research masters, which reflects the amount of independent work people are doing and would just show that they didn't have the same amount of time on the program.
So tell me about the students who are enrolling. Like, what are their backgrounds? And there's 11 of them that are starting out and joining the students we have enrolled. But so why are these students coming?
Honestly, doing the interviews for all of these students, and I got to interview all of them, was so much fun because of its nature, CoROM, having a focus on austere, remote rural medicine, attracts people who come from those backgrounds. And so I naturally have an affinity with the people who apply because we've got these shared backgrounds and shared experiences of some of the challenges, and then the interest of someone coming from a different setting. So we've got students coming from Canada and the US, got students who are based in the Far East, we've got students based in Africa, and from different healthcare professional backgrounds as well. So physiotherapists, nurses, physicians, I think an occupational therapist. So real range of backgrounds, and the shared common problems of being remote, limited resources, limited access to specialists, but then slightly different depending on whether they're working in a very low income setting or they're working in quite a high income setting, but covering huge geography. So really, really enjoyed talking to everyone. And it was also interesting finding out what research interests people had, because austere medicine covers a huge gamut of different types of medicine, as you know. So we have people who are interested in tactical and operational medicine, we have someone interested in dive medicine, and then lots who are looking into how you manage rural healthcare systems in terms of staff training and recruitment. So a really good range, and I think coming back to that kind of desire I have of building a sense of community for our students, I think having those commonalities, but with the richness of coming from different places, is going to make it a lot easier to build that sense of community, because I just instinctively find these people who apply to our course so easy to talk to and so enjoyable to talk to. So hopefully that's going to be something that they find they share when they're talking to their peers.
That is the beauty of the DHS, isn't it? And this is our etiology of this is the vastness of what people can study. People can. I heard someone talking about prolonged field care, getting a doctorate in PFC, or so this is fascinating to see what these people are bringing to the table. Their passions. It's this DHS allows people to pursue passion.
Yeah, exactly. And we've got people who have prior research interests they're wanting to pursue further. So the dive medicine example is a good one there, or someone who's wanting to continue research they've started into mass casualty incident triage algorithms. And then we have other people who have a problem but haven't yet worked out how to research that problem, or for instance, who work in a service that's providing really interesting, austere pre-hospital medicine, but they know their service isn't studying what they're doing. So they say, my service has all this data and we're not doing anything with it. What research should we and can we be doing? So it's going to be really, really fun over the first couple of years working with students as they start hammering out the exact direction of their research and then figure out the methodologies they're going to use, because it's, like you say, it's a huge, huge range, and then people choose one niche that is already their area of passion or their area of expertise, and they get to dig really deep into that. So it's going to be fascinating.
Let's talk about the elephant in the room, AI. So at the moment, there's a huge, huge hubbub in academia on the use of AI. But I did read one of our students' thesis concepts, and that's AI. So we have someone going through our DHS program, maybe more than one, but is just focusing on AI in healthcare.
Yeah, so AI is really interesting. I would say I perhaps have a more conservative approach to AI than some people have, but I think you'd be an idiot to say AI has no role to play in science or academia. As you say, one of our students is studying using AI to enhance the way people can make literature searches. And so clearly there's a big role for AI in improving and refining research or increasing efficiencies. But the real problem comes with generative AI and people using it as a shortcut for actually putting words on the page themselves. And I think, as you say, that's going to be, and it already is, a huge challenge for educational institutions, because the AI detectors are very flawed. I mean, they more or less don't work, or at least they don't work well enough to use as the sole evidence that somebody has used AI to produce a piece of work. But if we're asking students to write an assignment, so for example, we have a module on medical ethics, and we ask students to write an essay reflecting on the ethical quandaries of a particular issue and relate that into different ethical models. If someone gets ChatGPT to write that for them, they haven't learned anything, or at least they haven't shown me they've learned anything, not only about ethics, but also part of the reason we ask people to write assignments is because one of the skills people need to come out of a doctorate with is the ability to write concisely, clearly, evocatively, persuasively, and to do that under a time crunch. So if people are using ChatGPT to do it, they're not learning any of those skills and they're not demonstrating any of those skills. So how can we say that they've achieved the skills of a doctorate? But on the other hand, how do you catch them? How do you prove it? And what's the appropriate response? I wonder if a solution that some colleges might start using, and whether we might have to if it becomes an issue, is requiring students to use an online word processor that shows work in progress, so that you can see they've put a plan and then a few days later they've written some of it and an hour later they've written some more. I think that would be a solution. And if someone wants to laboriously copy and paste from ChatGPT every 3 days or a couple of hours apart to make it look like they've written something organically, we can't stop them. But I suppose we're trying to make it easier to do the skill as a human than to use a shortcut. What do you think?
Well, that's something we can easily do in our Google platform. So our Google Sheets and Google Forms. That's it's a challenge because the cat's out of the bag. Let's face it. There's people who
Yeah,
are making just about everything with AI. I use it all the time, but the
yeah,
thing is, I verify everything. So,
hmm
like people, people write a great article that's or a journal piece that I'm going to use, and AI finds it and gives me a DOI number. I always check the DOI number. I'm at about
yeah,
25% that the chat GPT DOI number is wrong. So I have to
yeah,
check every DOI number and everything that they give me, which then
hmm
adds to my critical thinking. So I think we can
yeah.
use AI if we also teach critical thinking side by side.
Yeah, and I think universities are going to have to start incorporating that specifically to teach that skill. And one way I could see that working, for example, is doing critical appraisal. Run a paper through ChatGPT, ask it to give you the, take-home message. Read the paper yourself, figure out the take-home message, and then analyze why you disagree with some parts of ChatGPT, because inevitably you will disagree with some of it. So I think you can use it to actually increase the learning of a particular exercise. I think someone would get a lot more out of doing that than from just reading a paper. But it's making sure they don't just use the AI instead of doing any of the human critical thinking. And another issue, because we're an international college, is using AI translation services. And that's an interesting challenge because, again, it's a wonderful tool. I think it's a really beautiful tool, really increasing the accessibility of works that are in a different language from your own. And that's fantastic. But at the same time, we're an English language institution. And if we're going to give a student a qualification that says they've got a master's or a doctorate from CoROM and it was conducted in English, we're telling any future institutions that that student has demonstrated technical language abilities in that subject matter in English. So we can't be saying that they can use translation from a native language into English for all of their assignments, because we need them to demonstrate technical skill in language. So that's a challenge as well. And again, it comes back to what you're saying. You can use it as a tool, and it's fantastic as a tool for language. You can do conversational practice with AI. You can use it as a technical dictionary to check jargon, to translate back and forth a few times to figure out if you've got your colloquialisms right, or to ask if you've got the tone right, because that's a real challenge if you're working in a second language sometimes. That's brilliant. But don't just write something, put it into Google Translate, and then hand it in as your own work, because
Yeah,
it's not your own work.
agreed.
Perhaps a controversial statement, but I think that's true. And people can do it as long as they acknowledge it. You can say, this was written in Spanish and translated by Google Translate on this date, this version, and acknowledge it. That's fantastic. I'm all on board with that. But not if you're claiming it is purely your own work and as if you'd written it in that language yourself.
I think that's good advice and that's a good way forward. And it's it's just going to get more convoluted. So we're at ChatGPT 5, which I think is rubbish. I'm using 4. It's just completely not. It's not evolving correctly. But who knows in 4 or 5 years what ChatGPT 10 is going to be doing? So we need to get on board early and start rolling out ethical
Yeah,
boundaries for chat.
yeah, yeah, yeah. And I mean, we've really only talked about the ethical boundaries of um, plagiarism and authenticity, and also the challenge of actually gaining skills and not using it to hobble yourself and prevent yourself from learning. But there's also other ethical issues about, generative AI's use of copyrighted material without the permission of those authors. And I would say that's perhaps an even bigger issue in the arts than it is in science, because frankly, most scientists I know who have publications would be quite happy for all of their publications to be open access, but it is still an issue. And, essentially, these large corporations that are making money from generative AI are making money from the copyrighted material of other people. And that's going to be a challenge that I don't think is going to be resolved satisfactorily for a long time, if at all.
Ella, it's been great to have you on the podcast again, and I look forward to seeing what you can do with the doctoral program.
Thanks so much for having me. And as I say, I'm really looking forward to starting to work with our incoming students of 2025.
Our next guest is Dr. Csaba Dioszeghy, who is an MD PhD. He's on our postgraduate faculty, and he is the program manager for our Masters of Austere Critical Care program. Csaba, welcome back to the podcast.
Oh, thank you very much. Absolutely.
You've been running the MSc Austere Critical Care program now for 4 or 5 years, and we are revalidating this every 5 years. We have to update and revalidate and improve it. What improvements do you have planned?
Well, so the MSc is a fantastic program. Let's start with this. So we're not improving it because it's not good. We're improving it because it needs to be even better. And we'll listen to the feedbacks. And there are a few feedbacks which we considered and found really, really good. So one is that there are quite a few people who'd really like to do the whole program fully online. Now, one big thing with the MSc ACC currently is that this is an extremely flexible program. You can start whenever you want. It's on your own pace. We do give you a lot of help to go through, but we understand that we're teaching people who are, it's austere critical care. So these people are students. Many of our students are working in, NGOs, sometimes military, other areas where they got deployed suddenly, unexpectedly, and they can't really stick to a strict academic schedule. So we're flexible. So that's a brilliant thing. However, currently we still have at least a week time in Malta, which is mandatory. Now, some people say that they can't even schedule that. We want to keep the 1 week in Malta because, first of all, it's the greatest fun. Everybody loves it. It's a great teaching. It's a great thing. But you can probably do it as an elective. So that is one of the major things we want to change, is that we're going to do that so-called iCare, so intensive care in a remote environment course, which is a classroom teaching, skills teaching and simulation and big fun and everything. So we want to do that as an elective, but we're also going to probably do it a bit bigger. I mean, we're going to have a specific online part of this, and we're going to have the teaching, and we can hopefully get a 15 credit specific accreditation for this module. So if somebody still want to come to Malta, which would be fantastic, and we will invite them, you come to Malta and you can get 15 credit, which is great. And likewise, we'd like to do our ultrasound teaching, which is also classroom teaching in Malta, as a standalone module with 10 or 15 credits. It depends on how we're going to master it out with MFAGA, so the Maltese Further Education Authority. So what we want to do with the ultrasound is that we can create this ultrasound teaching in Malta, again, another elective module with 10 or 15 credits. It depends on how MFAG will accredit us, how much we can put into this. We'd like to do it focusing on austere and remote and resource limited environments, of course, and pre-hospital, but we still need to see what exactly we're going to put into this to get 10 or 15 credits. So these are the two probably major changes. So once again, number one is that the already very flexible MSc ACC will be even more flexible and could be completed fully online. And the other one is that we're going to have more exit awards, more ways to get credit, enough to get a PG cert, for example. So just as an example, you can actually get a PG cert about ultrasound or a PG cert about intensive care in austere and remote environments like iCare. And there are some other modules we want to introduce. They are all elective modules. I'm really keen on starting a paediatric critical care course for the remote and resource limited area, obviously. And the other one, which is more because of the feedback, is a specific module about resource allocation and triage in these austere environments, including the ethical decision making and sort of things. So those are the two other modules I'd like to add.
I'm putting together a couple of modules that are found in the UK Advanced Clinical Practitioner programs. So anyone who would like to take our Masters of Austere Critical Care can match the modules that they would need to be an ACP, Advanced Clinical Practitioner, in the UK.
Yes, absolutely. This is one of the other interesting and probably important things. So we try to get more aligned with the UK advanced clinical practice training system. In my department in the UK, I have lots of ACPs working with us. Very, very successful program we have. But I understand that they are struggling to find a good master's program, which is flexible enough to allow them to do it with their clinical work. And I think our program is perfectly matching, except at the moment we don't have all the modules. So the other thing we would like to introduce is a pathophysiology module, which aligns with the UK requirements.
Yeah, definitely. And I think someone can pick and choose on the electives that we're offering to be able to match the ACP curriculum if they want to. And the nice thing is every one of these modules are focusing on the remote, austere, and resource-limited environments.
Absolutely. For clinical practice, that's another area we are very, very successful with KCMC. So the Tanzania clinical practice, we have negotiations with other places. And if we are successful with this UK advanced clinical practice system, then I'm sure that we can have UK-based clinical practice places as well.
Yeah, that's one thing we'll look at. At the moment, we're fine with our clinical placements in an austere environment, but to be able to bolster them a bit, we're looking at the UK. I'm currently in Sweden. I have appointments this week with some of the hospitals to get clinical placements up here for our bachelor students and the master students. So that is one area that our feedback from the students have been wanting a bit more flexibility on the clinical practice.
Yeah, absolutely. I think flexibility is one of the key things. And currently we have 46 students in the program at the moment. 46 or 40? Sorry, 40 actually.
Wow.
49. Everybody, without fail, feedback that the flexibility is one of the greatest advantage of this course.
And we do that. We have good faculty that are running each one of the modules that are allowing this flexibility. We've hired in a few more docs to help run this. Sean Bilodeau is the latest one who impressed me because he started out as a nurse and then he went to med school, and it shows. It really shows that. And Csaba, you started out on the ambulances as well, didn't you?
Yeah, I was a paramedic. Well, actually, I was an EMT when I was 18-year-old. I started that like that, and I just built it up. And that was the best days of my life, to be honest.
Yeah, I remember the EMT times way back in the 80s, and it's just you didn't have a care in the world.
Yeah,
and it just it was a very austere. I hate to say that, but man, it was austere environments back then, wasn't it?
Well, definitely. In my place, it was even a defibrillator. It was a big thing. Anyway, so going back to MSc, the other thing I wanted to mention is that now we have more and more students doing their thesis work and studies. And we got really nice theses, dissertations just defended recently, and really nice work. And the other thing is that we do have some collaboration with good academic sites all over the world. You managed to broker out a few really good connections.
Yeah. So Kumasi in Ghana, we just set that up last year. John and I went there to audit the location, and it was fantastic. And so we're getting more and more locations. Last month I was in Siafolk in Hungary, or is that Siafolk? Siafolk in Hungary, right on the beach, and setting up clinical placements there as well.
Absolutely. And with that, with the Semmelweis University, we have a really strong working relationship with the academic work. So there are lots of little studies are going on, which people can join in if they want. And they got really good academic help as well.
One thing that will stay the same with this revalidation is the requirements to enroll into this master's program is a 2-year university. So in the US, all you need is an associate's degree, or in England, it's a foundation degree, a 2-year degree. In the rest of Europe, we call it a higher diploma. For some reason, it's a 2-year degree. So any medic, doc, nurse, or any healthcare provider with an associate's degree can skip the bachelor's degree and come right in and take our master's of austere critical care.
Yes, with the only additional requirement is to have some clinical background in this case. So if you do not have a bachelor degree, you have a foundation degree, then you need to have at least 2 years sort of clinical experience. And I think that's pretty easy, because people don't usually start a master's degree without some level of clinical experience. And if you want to really learn critical care in the resource-limited environment, you first need to really understand what critical care is. And for that, you really need to understand some clinical background, basics. So that's the only environment we didn't have any problem with so far with our students who applied. They're actually quite senior quite often. There are quite a few doctors, there are quite a few paramedics, but there are nurses as well, and really very, very, very nice and hardworking, really committed team.
It's one of my high points in my calendar year is to come to Malta, run the eye care, and just see the motivation that is coming off of this master's degree.
Yeah, absolutely. So the eye care, it's going to be in about 3 weeks' time now, isn't it?
Or yeah, 3 weeks in Purdue, Malta.
Yeah, we'll see each other here. I'm also very much looking forward to meet face-to-face with these brilliant people.
Yep. And we'll continue to take the advice of our students and our recommendations from our students and continue to apply their suggestions for improving as we go along. And we're going through the 5-year upgrade now, and by April, it'll be in place.
Yeah, that's great. And again, it just increases our flexibility, and we really listen to their feedback and really consider that.
Well, Csaba, thanks for the last 5 years of running the Masters of Austere Critical Care, and I look forward to the next 5.
It was an absolute pleasure, and I hope that it's as pleasurable and as enjoyable to study this course as pleasurable and enjoyable to teach on this, because it's brilliant.
Our next guest is Dr. Nick Zuber, who is a PhD paramedic. He runs our Masters in Global Health program. Nick, welcome back to the podcast.
Thanks, Aebhric. I appreciate you having me on again.
So we're starting our next semester. So Nick, what do you have planned for the MGH this year?
Looking at stuff, I'm kind of excited because this is the first time, as you know, I took over mid-course last year. So there's a lot of things I learned, right? And so from our graduates last year, I get to go back in and kind of polish some stuff and update some things. And so it's exciting to be able to put my spin on some of the source material and those kind of things in the coursework this year, a little bit more than I was able to last year.
So who are the students enrolling? So we had a couple graduates last year. So who are they and who is it that's taking this MGH program?
I think so. Last year we had 2 gentlemen that have really significant remote medic experience, guys that are working in austere environments who wanted to level up and they wanted to have a greater kind of understanding of, lack of better terms, the business side or the management side of healthcare. And so those folks, it's line providers. It's not just medics, it's nurses. It can be physicians where, hey, I've been the bedside and I want to learn something a little bit different. That's just not direct clinical care, because clinical care doesn't happen in a vacuum, right? There's policies, there's budgets, there's, administrative decision-making that happens that someone has to do. And if we don't kind of know how to do it and specifically speak that language with the non-clinical folks, it's really hard to accomplish that sometimes. So those students are folks that want to kind of embrace that. How do I manage change? How do I look at analytics and risk versus just pure bedside and clinical stuff?
So this is the Masters of Global Health, and there's also Masters of Public Health. So can you explain the difference? What is the MGH versus the MPH?
Yeah, I think so. Here in the States, you probably see MPH more often. And then when I look internationally, I see global health more often, which makes sense, right? So global health, it's there in the name. We're looking at bigger issues that are more worldwide, that may cross national borders. So if you're a remote medical provider, you're dealing with different patient populations and not just one all the time. I think that's kind of a big indicator versus public health is usually more like country or region or even a community or a specific population within that community. So it's a little bit more focused and you're really often defined by a national border versus like this worldwide perspective that global health may take.
So MGH has more of a global look. I don't know global's in the name, but MGH is going to have a bigger picture than the MPH. Is that right?
Yeah, I mean, that's kind of the way I view it. There are crossovers. I think one of the things that the global health world does a little bit more than public health is looking at multidisciplinary things where it's not just very directly, epidemiology related things, right? Say, hey, we're looking at disease, but the global health is like, how do we learn to be a better leader? How do we create change? I mean, imagine when you've been involved with a change at work. There's a new policy, there's a new protocol, there's a new, item you've ordered, or like now there's a new software that comes out how you're going to chart. You've had that experience where they just drop that in your lap and you're like, this is what we're doing now, versus there's actual change management models out there that if you follow those, you can have much more buy-in and success. And it both lays out how you may experience that as the leader, bringing that change in, and how your constituents may experience it. And so if you take that as, a pre-hospital provider or a remote austere provider, and hey, we're going to do something different on this expedition. I know you guys have done it 20 times this way, but this is why we're changing. And having some framework to talk about, hey, we're going to lead change. And, we've looked at old data, we've looked at analytics, and we're going to do this differently based on that data. I think that's really, really strong lessons to learn, and bringing that to the bedside can help you be way more employable.
So for the paramedic working either austere or in the back of a rig, or nurse working on the wards, or a new doc that's just kind of starting out in his career, how is that going to work? How is an MGH going to be a benefit to them? So how would their reality change by taking our MGH program?
I think anytime you gain more knowledge and creating that bigger framework for you to work from, you're always better, right? So knowledge weighs nothing. You bring it with you everywhere, and learning about different ways to think about stuff. So again, hey, you're a new physician, and you walk into your unit on the ward and they're like, hey, we want you to manage this project. Well, there's whole disciplines that talk about project management, right? And so learning how to take a project from its initial birth to its full rollout and maintaining that, and, gaining consensus and really engaging your stakeholders can make your life much, much less stressful when you're trying to, manage complex things and complex organizations, right? Hospitals are giant living beings. Nothing should be happening in a vacuum in the hospital, even though people love to silo themselves. And so learning how to manage a project to that is huge, right? I think that just makes you a stronger provider. You're more versatile. You're not just clinical. And I think that's makes you vastly more valuable.
I remember there was a few of us sitting around a table about 5 years ago there in Pretty Bay. And some of them were paramedics, some of them were nurses, and I was asking them, they're in for courses. I sat down and I said, okay, what options are there for you? So the nurse, like, I can go be a nurse practitioner. The paramedic, well, I can go be a PA, or I can do, and I kept kind of asking, like, what's missing? Like, what could you want to get jobs in the industry as a nurse or as a paramedic or as a junior doc? And then the concept of MSF or ICRC, and of course there's medic jobs in UN and World Health, but to be more in the managerial side. So I heard from this group that people with an MPH and MGH are getting jobs. And then I looked on the websites. I looked on the World Health website, the MSF website, and looked how many jobs are available for an MPH, MGH. And there were tons. And what's interesting is when you look into the job, it says MGH or MPH. They didn't mind which one. So that's why I then sat down with very smart people, smarter than me, and I'm like, okay, we want to offer an MGH for our austere community. How is this going to work? And so that's why a bunch of people got together. And now you have that program and you're making it better. In fact, it's coming up for revalidation in a year and a half. So you get to completely tweak this to any way you like. But this would give jobs for international work as well.
Yeah, I think it rounds you out. You come, again, American perspective, I'm going to take care, but I think there's more to it than just this perspective, right? When you hear the word paramedic or nurse, there's a very strong visualization when you tell people that's what you do about like what your job is, right? You get in the ambulance or you work in the hospital, you're in scrubs, you're in a uniform, you do these direct patient care things, but there's this whole other world of challenges that need to be done in order to provide that care, right? And so this makes you more rounded because you can be a great patient care provider, but if you don't understand, how to manage that project, or organizational behavior, believe it or not, I mean, there's so much congruent stuff out there in leadership and organizational leadership that doesn't cross over to our bedside, that can completely change how you do your job or how your employees or your team experiences your job. Human behavior is everything, right? And so I think that's what this does. And that makes you employable besides just the bedside. Again, being a pre-hospital guy, people always talk about there's just that you're one injury away from a new job, right? So building depth in your knowledge and your skills and abilities is huge. And there's stuff in here that I think you can apply all the time, even if it's just, at the small level in the back of your rig or in that A&E department or something like that, when you want to, create change or have a new project or just create new, thoughts.
I look at this as a two hats. It's a second hat. So it's almost like a double-barreled shotgun. You're a clinician and you're a manager. And if you're going to work for the MSF or World Health or disaster relief, and you're there and they hire you because you have MGH after your name, but you're also there as a clinician. So you could be in country in this devastated earthquake location, and they're like, oh, wait a minute, you're a nurse as well, aren't you? Yes, I am. Can you help with this wall of people who just walked in? So you have two very highly sought after capabilities.
Yeah, I agree. I mean, it's being the Swiss Army knife, right? If you're a tool that's only a hammer, everything's a nail. If we only view stuff purely through a clinical thing, and they're like, this is what we should be doing, why aren't we doing it? This is what the patient needs. Well, if we haven't figured out how to get the logistics supply there, or navigate local politics and stakeholders, or develop good policy that educates our people and prepares them to go into the field, how successful are those clinicians going to be? They're not, right? Like, we're not setting them up for success. So having that great project plan or foundational knowledge of how you manage change, it sounds kitschy, but like, if you look at those, I guarantee when you look at those change models, you can go, Aebhric, oh man, I've been there and I've been there. And what if we anticipated that when we brought the new, policy out versus just like, oh, well, figure it out as we go, right? We've been there. I know you've been there. I know, I've been there. And so this adds a little academic and formality to it that you can go back on this knowledge to be more of a Swiss Army knife out there in the field.
So what are the tracks? What topics are people studying or what has the thesis topics been so far?
So far, my guys, the last two really leaned into adult education. Both of them were working kind of in remote areas where they were dealing with local folks that they had to educate, and how do we do better adult education? I think that's a big track, but those are just two products, right? Those guys had passion for education, so they kind of focus on that. But that's what's great about grad school. I when I talk to people, I'm like, dude, grad school has changed my life 100%. And I really, really mean that. That is not a sales pitch. Grad school is why I'm sitting here talking to you. And so education opens doors. And I think a lot of folks have maybe a negative experience with their undergrads, and they get into grad school where they have a dissertation, and you have a chance to take theory that you learned in class and take your professional experiences and things you want to learn and change, or that you see a problem where you work, and make that into your final project, right? Hey, I'm really interested in studying how we, manage change with a new patient care software. We just did that at the hospital I work at, right? So years of time, a lot of hurt feelings, a lot of learning, a lot of new things. And so that could be your dissertation, right? You can look at how you bring a new way of taking care of patients. So we talk a lot about prolonged field care, is bringing that into the standard street medic who may hold the wall for hours, right? Should that be part of their education? Can we look at that? So that's the dissertation there. You can do a lot with it. And you go to your committee and be like, this is what I'm thinking about doing. Is there research out there? And can we build off of that? That's the sell, I think, of the dissertation project at the graduate level, is it's much more choose your own adventure than undergraduate work is.
That's the beauty of the MGH. It's just so wide open that you can choose to focus on just about anything and so the last two guys were talking about educational interventions. So you can come up with, I want to do ACLS in austere environments and look at ROSC capabilities and adjust that with a Mu score or something. I don't know. There's just nothing that you can't do with the MGH.
Yeah, I mean, that's I think the big sell is, leadership is leadership, but there's, types of leadership may work better in the pre-hospital environment or internationally, or, hey, we're doing research. That's a core thing. If you learn basic research design and understanding how to do critical appraisal on a paper and working through methods and methodologies, you can bring that anywhere. Like, I've used that where I work when we go into, hey, like, we feel like we're really busy, but let's really dial down and be like, okay, how much time do we spend on a call? How far are we traveling? So those things like that can actually really change your perspective, because data can be a strong driver, and it's not just, numbers, it's not just quantitative, but quality of data. The qualitative stuff matters too, and even more so in this world where it's really hard to always measure a number, but you can measure an experience to some extent.
Here in Europe, there's a very hot topic of global health engagement. I've talked with yourself and other people from the States where that's just not really discussed very much. And Dr. John Quinn, who's on our faculty, every third word out of his mouth is global health engagement. Hey, we're going to, global health engagement. So tell us about what is global health engagement and how is that going to influence a paramedic or a nurse on the ground?
We were talking about that kind of earlier, and I think the big place that you see it is in the military world, right? So the DoD here in the States or NATO in Europe. And really it talks about a couple key things, right? The big overarching thing is, how do we figure out cooperation, not just between, different militaries that are allies, but within the community. So like the civilian community that they're doing hospital work with and stuff like that. Interoperability, how can we work best together? If we're taking patients from, one country's service to another country, they go into the civilian hospital and come out, what does that look like? Because at the most basic level, medicines have different names, right? There's whole books, or there used to be whole books. I haven't seen one in a while, right? Tylenol or paracetamol. If you don't understand that interoperability, you can have a bad day. And so when you come back even larger, how do we make the force ready with our partner nations, creating really strong structured engagements that build trust and maintain access, to strategic levels of thought. And as, conflicts continue to grow there in the European space, I think there's a big room here for this within NATO. And that's where it's talked about a lot. Like I said, how do we prepare for big strategy and practices across multiple organizations, both military and civilian?
So it sounds to me like your master's in global health program covers vast amounts of topics. So we talked about interoperability within NATO, and we talked about using this in a public health. As an MGH, you could work in a local city in the U.S. where you're just basically a public health official. Talked about leadership and global wise, looking at MSF or Medicine Sans Frontières, disaster relief, the UN. There's tons of options for an MGH. And you have the challenge of all of these people are coming to the door to take your program. Each one of them is going to have their own passion, their own thesis, and their own push to make the world a better place.
Exactly. And that's why I like this course, because you can bring that personal experience, and you don't have to be a pre-hospital person. You could have worked in the hospital. You could have never left your country and only worked in your little area. But it's teaching you foundational knowledge and foundational academics. You can use research design anywhere. You can use systems thinking versus being, reductive in any problem that you face. And so it doesn't matter your background, right? These are all very applicable things versus, just learning about a very specific disease, right? That, well, I don't have that where I live and I'm never going to run into it. These are, more conceptual. Hey, how do I solve problems? Everybody's got a problem.
Fair enough. So, Nick, I'm thrilled that you've taken the MGH program. You and I have been talking about austere medicine for 2 decades. You and I go way back. And now you're on our faculty. You're taking this by the horns, and I look forward to seeing what you can do.
I appreciate it, Aebhric. I'm stoked to be here.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.